Okay, everybody. Well, thanks for logging on. We have a great guest today. Dr. Ryan Tedford is joining us from the Medical University of South Carolina. Just to introduce Dr. Tedford here a little bit. So he's went to school in Texas initially, attended undergrad at University of Texas in Austin, and med school at University of Texas Southwestern. There moved on to Baltimore for his postgraduate medical training in medicine and cardiology and advanced heart failure at Johns Hopkins, and stayed on faculty there after completing his training. He eventually became an associate professor at Johns Hopkins and was the director of mechanical circulatory support and cardiovascular hemodynamics. Later in 2017, so about 5 years ago, he was recruited to become the chief of heart failure and medical director of cardiac transplant at the Medical University of South Carolina in Charleston, which is where he still is at this moment. He's also the director of their fellowship program at the Medical University of South Carolina, Heart Failure Fellowship Program. He is a professor of medicine and cardiology and holds the Dr. Peter Gaze's Endowed Chair in Heart Failure. Dr. Tedford is quite well known amongst the heart failure community. His research efforts focus on the hemodynamic assessment of right ventricular function and its interaction with the pulmonary circulation and left heart. So spanning the fields of pulmonary hypertension, left heart disease, exercise physiology, hemodynamics, systemic sclerosis, and mechanical circulatory support. So I was really interested when I saw this paper published by Dr. Tedford and his colleagues, as you know, it again addresses something that we run into quite frequently. And I think something, you know, as we were talking about one of our cases, our current patients in our prior meeting, you know, how do we anticipate who's going to have RV dysfunction or RV failure post-VAD implant? So excited to hear what Dr. Tedford has to tell us. And thanks, Ryan, again for joining us.
Well, Michael, thank you very much for the kind introduction, the invitation. This is fun to be able to actually kind of go into depth on a single paper. So I have a few background slides, kind of what prompted this evaluation, and really look forward to your comments and your feedback. Clearly, there's more that needs to be done here. So these are my conflicts of interest, hopefully, which will not be relevant. So I thought to frame the discussion, it would be best, and Michael, you said that you had a case recently to frame it with a case presentation. So this is a 62-year-old man with a non-ischemic cardiomyopathy. He had a big dilated left ventricle, ejection fraction was low, severe mitral regurgitation. He had a dilated RV on echo with subjectively quantified mild to moderate systolic dysfunction, although the formal TAPSE read was 19 millimeters, and he had moderate tricuspid regurgitation. He had a history of polysubstance abuse with ongoing tobacco and marijuana use, and so therefore, at the time, he wasn't a candidate for transplant at our center. Kidney function was normal, although his BUN was elevated, liver function was normal. So this was his resting right heart catheterization. Blood pressure was 105 over 78, heart rate was 88, right atrial pressure was borderline at 6. He had a positive hemodynamic Kussmaul sign. He had moderately elevated pulmonary pressures with an elevated wedge pressure, which we confirmed with a wedge saturation. And you can see his cardiac output and cardiac index was quite low with an index of 1.1. His pulmonary vascular resistance was elevated at 6.6 Wood units. When you look at kind of traditional hemodynamic markers of right heart function, they were favorable. Right atrial pressure to wedge ratio was 0.3 and a Papi was 3.3. Now, because at the time he was still undergoing a transplant or a evaluation for transplant as well, he received nitroprusside. This predictably lowered his systemic blood pressure. You can see his right atrial pressure did not actually change. His mean pulmonary artery pressure and wedge pressure declined. His cardiac output increased, but just modestly. PVR remained elevated, and you can see that his stroke volume index was still quite low, and his Papi actually declined a little bit. So traditionally, this is not someone that would be considered high risk for right heart failure. So what happened? We actually implanted him via a hemisternotomy and an anterior lateral thoracotomy, so a less invasive approach. Bypass time was relatively short, had good cannula position, but despite that, had at least moderate RV dysfunction coming out. He had an elevated CVP and lactate, required moderate doses of inotropes and inhaled nitric oxide. He had some bleeding. We noted the chest tube output, and he developed some acute kidney injury that ultimately resolved without dialysis. When he arrived in the CVICU, he was having lots of suction events, which required pump speed lowering, and then a slow inotrope wean over 16 days, along with significant diuresis. So we'll go over the definition of right heart failure, but he would meet the most current definition of early right heart failure. His overall length of stay was 22 days, which is a bit longer than we like, although he recovered very nicely. And he's currently out 16 months with his VAD, and he's actually on no diuretics at all, which I would say is probably the most sensitive marker of RV dysfunction. So the question is, could we have predicted right heart failure prior to implant? And then why the heck is it so hard? And people are all aware in this group that if you develop right heart failure after a VAD, it's really bad. And it's bad early on, and this persists throughout certainly the first year and is and likely longer. So what are our traditional ways to assess the right ventricle? We can do it hemodynamically. Some of the factors I mentioned to you, that RA pressure to wedge ratio. We can look at pulmonary elastance. We can look at the Papi, which is the pulmonary pulse pressure over right atrial pressure, right ventricular stroke work index. We can look at echo, right? We can look at the RV size and function, either quantitatively or qualitatively. We can look at things like strain, the TAPSI to PAPSI ratio, which is probably the best non-invasive surrogate of so-called RVPA coupling. We can get a little bit more sophisticated. We can look at MRI, probably the best fidelity in terms of RV structure and function. But really, none of these work very well in isolation to predict right heart failure. So what do? Well, we get residents and fellows to develop risk scores for us. And this was a review in 2017, and there were 29 risk scores. And I think in the last 5 years, there's been at least an additional 29 of them. Unfortunately, none of these work particularly well in independent subsequent cohorts. All have very modest discriminatory power. These are some of the early risk scores, but really no better than the flip of a coin when it came to determining who had right heart failure. Probably the largest, or the risk score that was derived from the most patients, was the Euromax right heart failure risk score. It identified 5 preoperative variables: the right atrial pressure to wedge ratio, hemoglobin less than 10, being on multiple inotropes at the time of implant, Intermax class 1 to 3, and then subjective severe RV dysfunction on echo, and then one post-operative factor, which was cardiopulmonary bypass time. And you can see at the time that this risk score performed better than some of the other risk scores, but when you look at the actual C statistic, it's still not great, 0.7, so still kind of modest discriminatory ability. So what about our patient? Well, his risk scores were all low. His Euromax right heart failure score was 0, Cormos was 0, CRIT was 1. So are there any other clues or ways to unmask RV failure? And as we think about that, I just want to kind of mention what happens to the RV when we put in a left ventricular assist device. This is a perspective that I wrote with my colleague Brian Houston and Mandeep Mehra and K.R. Shah a few years ago. If you're confused about right heart failure, I'd recommend that you read it. After you read it, you'll still be confused, but perhaps at a higher level. The central theme here is the septal function of the heart really changes dramatically after an LVAD implant. And there's a number of factors that contribute to that. One is the loss of pericardial integrity reduces LV twist, and LV twist is responsible for a lot of that longitudinal motion. And we know in a healthy RV, about 80% of RV function is due to that longitudinal motion. Having the LVAD out at the apex of the heart also reduces LV twist. It kind of anchors it down a little bit, so this contributes. We know that RV volume overload or too much preload will cause that septum to shift over, again, reducing its function. But then the other major factor here is that we reduce LV preload. And we know that RV function depends on LV function for about 50% of its contractility. So as we reduce LV preload, we're going to reduce LV contractility, which reduces RV contractility. When we lose our septal function, we also become more dependent on the RV free wall, which is composed of circumferential fibers. These fibers are much less efficient with contractility. They can compensate for the loss of septal function, but we have to assume that they're not, one, adhered to the chest wall, or they do not have to squeeze against high afterload with pulmonary hypertension, and those factors are variable after that implantation. This is just one physiology experiment that really shows the impact of unloading the LV on RV function. So here in this rat model of chronic RV afterload, you can see that the LV is being decongested. And in doing so, when you look at these load-independent measures of contractility, in-systolic elastance, and preload recruitable stroke work, you can see they really dramatically decline with LV unloading. So what is the best way to assess RV function? Now, I can never give a talk without showing at least one PV loop, and I promise this is my only one. But this really is the gold standard to look at load-independent contractility and afterload from the pulmonary circulation to determine RVPA coupling. Now, as much as I love RVPA coupling and pressure volume analysis, I'll be one of the first to admit that this is probably not feasible for clinical practice. And in fact, Stephen Hawking once said, PV loops may be possible, but they're not practical. So with that in mind, what else can we do? And I would say that one possibility is to look at RV reserve. So what is RV reserve and what information can it give us about coupling? Well, first of all, contractile reserve is the capacity of the ventricle to increase contractility at a given level of loading. And that's typically determined with exercise or a pharmacologic stress test like an infusion of dobutamine. This is an animal study of a piglet model of pulmonary hypertension where they performed pressure volume analysis to determine RVPA coupling, and then they looked at the response of dobutamine to stroke volume index. And you can see on the left-hand side that the piglets with the most severe uncoupling had the least increase in stroke volume index. And on the right-hand slide, a relatively linear relationship between resting RVPA coupling and relative stroke volume index reserve. We looked at exercise reserve in a cohort of patients with either known or suspected pulmonary hypertension, and again found at least a modest correlation between resting RVPA coupling and exercise RV ejection fraction. There was actually no relationship between resting ejection fraction. So can we do this type of testing in patients with who are candidates for durable MCS? This was a paper that was published in the Journal of Heart and Lung Transplant about a decade ago, and it's remarkable to me because it was only 6 patients. I'm not sure JHLT would let us get by with that today, but 6 patients who had biventricular failure and underwent dobutamine stress echo. What they found is that those who did not develop right heart failure, which is the dark squares, could increase their systolic pulmonary artery pressure more than those that developed right heart failure, and perhaps modest differences in TAPC, although obviously there's a lot of overlap there and the numbers are quite small. But the problem with that approach is that many patients who need durable MCS are already on inotropes, they're already on dobutamine, unless there's a shortage, and they can't really exercise. So could we define reserve a bit differently in this population, leveraging, we know the impact of what happens to when we unload the LV on RV function. So could we define reserve as the response of the RV to LV unloading with either pharmacologic, as in our case, or temporary mechanical support? And so to explore that idea, let's just talk a little bit about what I call conservation rules. And that's for any given cardiac output, the heart rate of the ventricle is the same. And so therefore the stroke volume in the left ventricle must equal the stroke volume in the right ventricle. So to say another way, that your stroke volume in the left ventricle is going to be limited if you have no right ventricular reserve. So let me show you what that would look like on a PV loop here. So if you have a patient with heart failure with reduced ejection fraction, you have a very high afterload and a low stroke volume being the width of the pressure volume loop, the black dashed line there. If you give that individual nitroprusside in your ICU, you're going to lower afterload. And in doing so, you're going to see significant increases in stroke volume, assuming you can maintain LV preload. And LV preload here being the end diastolic volume. So you can see that loop, the part on the right of the loop really did not shift at all. On the other hand, if you lower afterload, but you cannot maintain LV preload because of lack of RV reserve, your stroke volume augmentation is going to be reduced. And so again, if there's no RV reserve, LV preload will not be maintained and stroke volume will not significantly increase. Okay, so with that background, let's get to the paper. And this paper was published online in the Journal of Heart and Lung Transplant this summer. This was a multi-center retrospective study from MUSC, University of Pennsylvania in Toronto. We found 70 patients who underwent a right heart catheterization, along with vasodilator testing, specifically with nitroprusside, as part of an LVAD transplant evaluation, but then for whatever reason, ultimately received an LVAD. So this is a convenience cohort, no doubt about it. All of these patients, per the provider in the cath lab, had a clinical indication for vasodilator testing. Almost all of those were because they had an elevated pulmonary vascular resistance greater than 2.5 Wood units. A very small fraction did not have an elevated PVR, but they had a very elevated systolic pulmonary artery pressure along with a high wedge pressure. Most of these individuals had the so-called combined pre- and post-capillary pulmonary hypertension. Average PVR was 5.2 Wood units. And then during the study period, 191 patients received an LVAD but did not undergo vasodilator testing, so they were excluded. So obviously a significant number of patients excluded because clinically they were not given a vasodilator. Now, right heart failure, and we'll get to the definition here, was the 2020 MCS Academic Research Consortium definition. And then we also had a follow-up cohort of 10 consecutive patients. So this is the definition of right heart failure, which is always a very important question when you're studying the right heart. We have early acute right heart failure, which is the need for an implant at the time of LVAD implantation. And then we have early right heart failure, which means you need an RVAD within the first 30 days, or you fail to wean from inotropes, vasopressors, or inhaled nitric oxide within the first 14 days, or you have to reinitiate it within 30 days of support. And then you have to have at least 2 clinical factors: ascites, edema, elevated JVP, or an elevated CVP or right atrial pressure, or 1 laboratory factor, essentially. So creatinine greater than 2 times baseline, elevated LFTs, a low mixed venous sat, a reduction in pump flow of 30% from baseline, low cardiac index, or an elevated lactate. And then finally, if you died within 14 days of LVAD implant from right heart failure, were included. So anybody who met those criteria were included as having early right heart failure. All right, so what did these people look like? Well, first and foremost, right heart failure was common in this cohort. It was most common at Penn, followed by MUSC, and actually less common at the University of Toronto. So 39% of people met criteria for right heart failure, and actually that number seems high, but with some of the new centrifugal devices, and the only one we really have commercially available now, the incidence of right heart failure has certainly increased. 20%, which are included in that 39%, had an RVAD. And half of those were planned. And that's a really important thing to remember and consider. As these RVADs have become more commonly used, they're less invasive. A lot of surgeons, a lot of programs will put these in prophylactically. And so this can bias results. Now, we tried our best to control for that by different analysis, but it's still an issue with any time you're going to study RV failure after an LVAD. So when we compared the characteristics of those who did and did not develop right heart failure, I can tell you that they were very similar baseline demographics. Intermax profiles were no different. They had very similar baseline hemodynamics on the right heart cath. They were small, but statistically significant differences in stroke volume index and mean pulmonary artery pressure. They were very similar and no different echo parameters. So LV size, ejection fraction, TAPSE, valvular regurgitation, no different. Similar laboratory values, similar degrees of kidney dysfunction, liver dysfunction, et cetera. And there was no difference in any of those risk scores that I described to you earlier: Euromax, Cormos Crit, or the Penn Columbia risk score. So what was different? And I'm going to highlight for you some hemodynamics during vasodilator infusion. I first want to show you that these 2 groups, those who did and did not develop right heart failure, received similar amounts of nitroprusside, and they received, we reduced mean arterial pressure to very similar levels. So you can see no difference in mean arterial pressure there. When you looked at the amount of change in wedge pressure and pulmonary vascular resistance, that was also no different between the groups. Well, we really saw the dramatic differences here was not in the ultimate wedge achieved, but was the change in, or was the absolute peak stroke volume index. You can see very different between the 2 groups. Also saw differences in the cardiac index that could be achieved, as well as the pulmonary effective arterial elastance. Those three factors I just mentioned to you have a lot of collinearity, so we really focused in on stroke volume index. And here is a ROC curve just showing peak stroke, baseline stroke volume index, the change in stroke volume index, and the peak stroke volume index with nitroprusside infusion. And you can see it's really the peak stroke volume index that had the best ability to discriminate those who did and did not develop right heart failure. When we looked at specific subgroups, I think important subgroups, this discrimination held in patients who had received a HeartMate 3, as you know, the only commercially available durable MCS device, which was a majority of our cohort. When we excluded those patients who required an RVAD, for the reasons I mentioned, we still found very similar discriminatory ability. On the other hand, when we defined right heart failure by perhaps the purest form, which is RVAD only, again, we found that nitroprusside and the response of stroke volume index predicted right heart failure. And then, you know, the time at which these right heart catheterizations occurred were variable because they were done clinically. So when we restricted to those who had a right heart cath just 6 months before the implant, which was majority, 61 out of 70, the same discrimination held. These were our predictors of right heart failure using logistic regression. You can see both univariate as well as two different multivariable models. And it was really only peak stroke volume index with nitroprusside that predicted in all models. Again, maybe not surprisingly, the HeartMate 2 LVAD was predictive of right heart failure in univariate as well as in the conservative multivariable model. This is a population pyramid, and what it shows here is if your stroke volume index with nitroprusside was above 22.1, the likelihood that you're going to develop right heart failure was relatively low. And so that can perhaps be helpful clinically. I mentioned to you that we had a follow-up cohort, and I'll be really honest with you, this was done because we had such long delays in revisions, and one of the reviewers asked us to, well, what's happened since you started this? And so we found 10 patients who had undergone vasodilator challenge. We were pleased to find that this classified, that cut point of 22.1 classified all patients correctly. And it was only peak stroke volume index that was different between those who did and did not develop right heart failure. Admittedly, a very, very small follow-up cohort. There's clearly some limitations of this work. The modest sample size, these patients are relatively rare. It's retrospective, and obviously only patients who had vasodilator testing were included. Right heart failure was lower at Toronto, although not in multivariable modeling, and so these tended to be less sick patients. We did not have measures of right atrial pressure, and so we cannot look at changes in Papi, for example, but I'm going to show you some data on that in just 1 second. And then, although in general, the practice at our institution and others is to stop nitroprusside when the PVR is less than 2.5, based on kind of our known practice in transplant, it's not completely standardized, and perhaps it should be different when we're investigating patients as LVAD candidates. So about 3 days after this was published online, there was another paper out of Europe with a very similar design that was published in the European Heart Journal, Acute Care Medicine Journal. And they also single center here, but we're trying to discriminate those who developed right heart failure from those that did not. And they found very similar results. So peak stroke volume index was different between those two groups, but they also had right atrial pressure, and they showed that Papi was higher in those with nitroprusside who did not develop right heart failure than those who had right heart failure. And that's illustrated here in this graph. You can see the patients who did not have right heart failure, which is pictured here, had a significant improvement in their Papi with nitroprusside, where the patients who had right heart failure really had no difference. Now, the last idea I just want to throw out there as we get into the discussion is we talked about unloading pharmacologically, but could we do this with temporary mechanical support? And first, I want to say that I am not advocating this in any way, but other than a discussion. Obviously, these are very expensive devices, and we do not use it for this purpose. This was a study that came out of Houston Methodist, where they took patients who already had an axial temporary mechanical support device, so it wasn't being put in for this purpose. And they looked to see the response to that device and if it predicted right heart failure. This first slide really just shows you their Uramax score before and after insertion of the temporary mechanical support. And you can basically see that it did not change their Uramax score. But when they looked at who ultimately developed right heart failure versus those who did not, you can see the ones that did not develop right heart failure had a more significant reduction in right atrial pressure, more significant reduction in wedge pressure, actually an improvement in their RA pressure to wedge ratio, and an improvement in their TAPSE. Again, very small numbers. I'm not advocating for this, but really just to open up discussion. So back to our patient, based on our study, I think it would suggest that perhaps this individual did have a lack of RV reserve, and perhaps we could have predicted that at least he would struggle in the immediate perioperative period. So to conclude, I would say that vasodilator testing or even temporary MCS to unload the LV may be another way to assess RV reserve and predict RV failure after LVAD implantation, though clearly prospective studies are needed to test this hypothesis. And I'll leave you with the importance of great collaborators and mentees. On the left is Jake Reed, who's the first author of this paper, who really led this work. He's one of our MUSC chief residents this year. And then two collaborative leaders, Susanna Mack at the University of Toronto, one of my favorite people, an expert physiologist, and then Ido Barati, who was at Penn and has now moved on to Israel. I really appreciate all their collaborations to make this possible. So with that, I'll certainly pause and would be happy to hear your thoughts, critiques, and maybe we could talk about collaborations as well.
Thank you so much, Dr. Tedford, for that wonderful talk. I guess before I open it up to the rest of the group, for my benefit, if you don't mind, would you mind going back to the slide from the European Heart Journal where you were discussing how Papi might be used to further determine who may or may not be at risk? I didn't follow this part of the talk so well.
Sure. So they simply dichotomized by those who did and did not develop right heart failure. And so the no right heart failure is the 35 patients, the middle column there. And you can see the stroke volume index was higher with nitroprusside in that group than those who developed right heart failure. Although, obviously these numbers are a little bit higher than the numbers that we got. And then on the bottom part here, the second red box, that is the the Papi after nitroprusside. And again, you can see higher in those who did not develop right heart failure versus those who did. And summarized here in this graph, the middle is those who did not develop right heart failure. You see Papi improved with LV and LVAD with nitroprusside, whereas in the ones who had right heart failure really did not change at all.
Okay. So am I understanding it right in that table beforehand that some of the patients that went on to develop right heart failure still had a Papi, nearly 2.7 plus or minus 1.3. So that's really interesting since, usually I think if I would see a Papi in the 2s, I would think they're in the clear, but.
Right. Well, and this is of course, this is a Papi during nitroprusside. So,
right.
I don't know how often we're looking at that as a predictor. I think, clearly they were lower at baseline. But I think, if you look here, the average Papi in that group before nitroprusside was right at 2.
Yeah, very interesting. Well, thanks so much. Anybody out there in the group have any questions for Dr. Tedford? If you do, you can just unmute yourself or raise your hand or put a question in the chat and I'll be happy to ask it for you.
Hey, Ryan, this is Tariq. Quick question. Fabulous presentation. So a lot of times, anecdotally, it seems that people look at the echocardiogram, and if the RV is very large and, hypercontractile, they just say, oh, this patient's going to be a bad LVAD candidate because, RV failure will occur. Did you guys kind of look at echo parameters and how they correlate with these indices?
Yeah, so we did. Let's see here. So this was table 1 from the picture, and obviously it's kind of hard to see. But so the middle column there is those who did not have early right heart failure, and then the far right column is those that did. And they're really indistinguishable either by by your kind of subjective, either your volume measurements, your subjective measures, or a little bit more objective, being TAPSE or the TAPSE to PAPSE ratio, but really not much there. And I think, it's included in the Euromax score, of course, just subjective severe RV dysfunction. And although I think it makes us nervous, Jonathan Grinstein makes an important point. So we know that the LVAD, when you go in to the LVAD procedure, kind of the contractility of the RV will decline for some of the reasons I mentioned. But the overall RVPA coupling still might improve, and it does improve in some individuals. And why is that? Well, of course, we're unloading the LV, and that's going to reduce RV afterload. So it's just this combination of which is going to win. Is the afterload reduction going to be enough to allow the RV to function, or is there going to be such a hit to contractility that you're not going to be any better or perhaps any worse? But so I think because of that, our kind of a traditional echo estimates, it's really hard to tell. So if we can, reproduce pharmacologically what's going to happen when we reduce RV afterload, that's to me kind of a best case scenario, because obviously we still have our pericardial integrity. We haven't insulted the septum. And so if you ever see a patient that falls apart, if their RV falls apart when we pharmacologically unload the LV, then I think that patient's really going to be in trouble. Despite that, right, none of these, even with a AUC of 0.8, 0.82, and that's without an external validation cohort, it's still probably not enough to tell somebody we're not going to put a VAD in you, certainly without a lot more validation. But I think, it can help a little bit with shared decision making. I mean, we had a patient, I will tell you, that had a temporary mechanical support device because they truly needed it. And when we put that in and unloaded the LV, their RV completely fell apart. And she was very much on the fence about it. And, she said, "Doc, I'll do this, but I need to be perfect after this." And I said, "Well, I'm not sure that we can tell you that based on what we're seeing." And she ultimately decided to go in a different direction. I think the other area, though, that this is really ripe for is if we can identify these high-risk populations, is that a group that we study kind of with empiric RV support at the time of implant, or perhaps a less invasive strategy with our LVAD implants. But I don't think these ever are going to be good enough to say you're not going to get a VAD per se.
I'm so glad you went down that path, because that's the next question I was going to ask you, because a lot of the LVADs, at least that we're doing, and seems like what's happening nationally, are the DT VADs, where patients don't really have any other options. So if you kind of know that someone's going to be high risk, I know that at least at our institution, we've kind of been thinking about maybe doing an Impella 5.5 to offload the LV, kind of getting, people used to that flow and see how they do, and then try to get them into the OR for the LVAD, or maybe even just start, RV support prophylactically, like you mentioned. With that, I mean, it is a data-free zone, and it'll be hard to randomize. I mean, do you think, what do you think should be the best approach to kind of minimize that risk of RV failure? Given that, with the caveat that obviously, like, no one kind of really completely knows the right answer.
Yeah. Well, and we do that a little bit as well. I think that we use a lot of 5.5 devices, and we have certainly used them to bridge patients to durable MCS, but I still think that they're associated with a fair amount of morbidity. And so I think we would definitely want to try to have a little bit more data before truly recommending that. I do think, though, that, we could use, either a combination of RV risk scores, or perhaps, data from a study like this to say, gosh, these folks are really high risk. And, let's randomize to those who we're going to put a less invasive RVAD in at the time of implant, or perhaps right before implant, as you suggested, especially if you don't have to run them on anticoagulation for a period of days, and see if the outcomes are better. I mean, I'm humbled by the number of patients that I think are going to do perfectly that don't, and the ones that I think are really going to struggle that don't, to know that, it's really hard to predict. I mean, I had a patient who actually fell apart on a 5.5, but we felt like the patient became kind of septic and the RV just went down, and we put a Protect Duo in, and we're able to, and we decided, because they were very young, and I can't remember, they were not a transplant candidate for a strong reason, but so we actually bridged them with that device in, and I thought for sure we were never getting them off the Protect, but in fact we did. So, I think maybe preserving some of that RV function, not allowing them to get overloaded, using high dose of inotropes, perioperatively might help. Now that's just, again, a guess, but I do think that's where this is going is, how do we, in these high risk patients, mitigate the impact of the RV in that initial post-op setting, and can we kind of salvage them through, through the implant.
Thank you, Ryan. That's very, very helpful. I mean, this comes up all the time, as you might imagine.
Yep, it's something we talk about a lot. I think we've shifted a little bit too. I mean, we've certainly become more aggressive with VADs. I mean, I think our transplant volumes have mirrored y'all's growth a little bit, and our VAD growth though has also increased. And obviously we've changed who we put VAD-ins. I think they're a little bit more forgiving. And so we kind of have a 3 strikes and you're out approach. So if your RV stinks, if your support stinks, and your kidneys stink, then you're not a VAD candidate. But if you only have one of those 3, then you're probably going to be okay. We can kind of nurse you through at least one of those 3, sometimes 2 out of the 3 if you're young. So I think we have been a little bit more aggressive, and then we're learning about what that looks like.
Dr. Villamkonda has a question for you.
Sure.
Thank you so much for that wonderful talk. I just had a quick question about the study itself with regards to your protocol of using nitroprusside. So in patients that do not have nitroprusside, in that cohort that didn't get the vasodilator challenge, I wonder if a metric that includes afterload, like a CPO, cardiac power output calculation, would potentially do the same thing that you're trying to answer, right? Because what you're doing is you're unloading with nitroprusside, and then you're taking away the effect of the afterload, and then just looking at the cardiac or the stroke volume index. I wonder, just keeping that afterload and then seeing what the effect would be with the CPO on the right side would give you something similar in that big cohort, because it seems like you have 190 patients that you could probably answer. I wonder if that will have more of a practical approach in guiding, if that shows results that are favorable, then in general, people don't do the vasodilatry challenge as much as the right heart, plain old right heart caths.
Sure. Yeah, that's a good question. I will tell you, so we had to go back and pull all this data, although we did not adjudicate right heart failure in all those patients. Now, we do that for our own institutional purposes, so we do have it on all of our patients, but not at all the other centers. So we don't have right heart failure adjudicated. It's a really interesting point. I don't think people have looked at CPO. I think it's still a little bit hard to differentiate the LV versus RV effects unless you're kind of unloading the LV. But we also didn't look at that in this cohort, and we could certainly go back and do that and see what that shows. That might be actually a pretty strong predictor. These were just comparing the ones that got excluded, and the wedge pressures were equally high in these patients. The PVR was a little bit lower. We think that, in general, they're fairly similar patients. They're actually looked to be a little bit sicker in terms of Intermax profile. But again, retrospective, and it's hard to eliminate some of these biases.
Any other questions from the group?
Michael, if you want, I'll mention one other thing.
Yeah.
So we have a couple minutes. So one of the questions I kind of get a lot is, well, what about something other than nitroprusside? One, I don't know if you guys use nitroprusside, but I love it because it's so easy to use. People get scared because it drops blood pressure, but it's on and off. I've never run into an issue. But for what, other institutions love milrinone. And so we partnered with a couple institutions. This is work from Greg Macaluso's group, looking at when patients were put on milrinone and 24 hours later, what it looked like. And none of this is this was presented ISHLT, but it's not statistically significant, but it's 48 patients. But you kind of get an idea that if with milrinone, you could increase your stroke volume index by 50%, your risk of right heart failure, which is the orange bar here, was really quite low compared to if you could not. And a lot of these patients were on multiple inotropes. And then similarly, Jonathan Grinstein and Mark Belkin at University of Chicago now giving bolus milrinone in the cath lab, which is how they test for reversibility. So nearly statistical significance here, looking at stroke volume index after milrinone. I think the issue that I have with this is that if you look at left heart filling pressures, they actually don't go down all that much, and so I'm not sure you're really replicating kind of the LV unloading that you're going to have with the durable MCS. But there's still, these are pretty small numbers. They're still with larger numbers, we might see a signal.
So given all this data, if you were presented with a patient that you were somewhat concerned about and you were evaluating for LVAD, I guess, what would you do personally to try to further evaluate them? And what clinical characteristics might push you in one way versus the other?
Yeah, so we've become pretty aggressive about looking at the response to nitroprusside, and I mean it's pretty routine. We do that in the cath lab if someone's undergoing advanced heart failure evaluation. So we look at that data, and then I think depending on as part of our discussions with LVAD, we'll discuss their risk and say, well, you may be a little bit higher risk here. I think one of the things that we believe in, and again, not a completely validated approach, but is that less invasive implant strategy. People are aware that was studied in the lateral study somewhat. This was compared with historical controls, the old HVAD device, and their length of stay was lower. There was less bleeding in the patients who had that thoracotomy approach, and only one patient required an RVAD, although none had severe RV failure. This was another paper that we had done with a couple groups in Germany and several in the US, looking at the risk of right heart failure after this less invasive surgical implant strategy. And our overall cohort and then propensity matched cohort, again, with all the retrospective biases potentially, we did find lower right heart failure in this group. I do realize that has not been replicated in INTERMACS. I have thoughts about why that is. If you look, 80% of the centers had actually performed 5 thoracotomies or less that contributed to that data. And so this is not a straightforward procedure. It takes a lot of practice. And so I think that's possible that it could account. And I promise this is the last slide I'll show, but we presented this at one of the pre-AHA meetings this weekend and also at HFSA. But this is our own data looking at load independent measures of contractility. So we actually took the RV pressure tracings, we digitized them, and then we did single beat estimates of contractility. And what we found is in the sternotomy patients, which is pictured on the far left, that contractility declined from before and after implant, whereas in the thoracotomy, they really was better preserved. And then when you looked out at 3 and 6 months after implant, the patients with thoracotomy were actually on much less diuretic, as measured here as median furosemide equivalents. And again, all these definitions of right heart failure have their challenges, but I really think about, the patients who thrive with VADs, and it's the ones that, aren't on a lot of diuretics. So to me, that is really a pretty good marker of residual right heart function in these individuals. So I would, have a discussion with them, and I would consider a thoracotomy implant, and then perhaps, as Tarek was mentioning, at least if not an upfront, at least a low threshold for RV support coming out of the operating room.
And here at our center, we don't see, I can't remember, maybe one patient having a VAD by thoracotomy. So I guess what is, just from out of my own lack of knowledge, what is it that makes the big difference with this? Is there some type of change in thoracic geometry that you think is affecting LV function or RV function, or why would there be such a big difference here with surgical approach?
So I personally believe it has to do with pericardial integrity. And so when you don't when you incise the pericardium, even in CABG patients, when you immediately incise it, you lose a lot of your septal function. Now, if you do restore the pericardial integrity, it does return to some degree. But I think it has to do, I guess, a combination of preservation of pericardial integrity, probably along with less bleeding that generally occurs. Obviously, the LVAD itself is anchored in the same position, so it has nothing to do with that. And then, there is some thought that you perhaps with a thoracotomy approach get a little bit better flow characteristics with a better optimization of the angle of the inflow cannula. There's an ongoing study called SWIFT, which unfortunately is not randomized, but it is a prospective study of thoracotomy implants with the HeartMate 3 device, and that will be presented at ISHLT. So again, it's not randomized, but hopefully it will give us a little bit more insight into is this one, is it completely safe, and then two, is it potentially beneficial for the right heart.
Any further thoughts out there from the crowd? Well, if not, Dr. Tedford, again, thanks so much for taking the time to join us today. I'm very excited to get to talk to you and get to meet you. And I look forward to meeting you again in the future. And thanks again, everybody, for coming out, and have a great rest of your day.
My pleasure. Thanks.
Ryan, thank you so much. Good to see you.
Hey, you too. Take care.